Many thanks for having me here today for this interesting symposium. My name is Mariusz Tomaniak and I represent the University Clinical Center of Medical University of Warsaw based in Poland. Let me start my talk by sharing with you this 76-year-old female patient with CCS-free angina despite optimal medical therapy. She underwent several interventions, both percutaneous and surgical, and at some point heart team decided to qualify her for conservative management. She had her anti-anginal medication extended and up-titrated. However, she still experienced debilitating angina that severely impacted her quality of life. Therefore, we qualified her for coronary sinus reducer implantation. And I did it following this simple four-step approach, which I will briefly overview with you now. So, first, we prepared the patient, and it's good actually to reposition the typical cath lab setup so that the scrap table was actually perpendicular to the patient in the lab, and so that the operators, or like in my case, me and my nurse, are to the right of the head of the patients that we treat. I take the camera LAO 30, and I do ultrasound to guide the right internal jugular vein access. Once I have the sheath already in the right atrium, I measure the pressure, which should be confirmed to be less than 15, we expect that the device efficacy with values above the 15 would be less expected. In majority cases of the cases, it's really below the 15, and here it was 7, so I could proceed with the implantation. So to do so, I engage the coronary sinus with MPA catheter. No push here, just with subtle rotation. I direct this catheter to the 4 or 5 o'clock, and once I'm at the ostium, I advance it further with a J-wire to optimize the position of the MPA, do the angio, and while evaluating the angio of the coronary sinus, important anatomical factor is the venous valve. I will come back to this in a moment. We keep in mind two facts: that the size profile of the reducer device is between 9.5 and 13 millimeters, and that we do intend to oversize the device approximately 10% to confirm its stability in the place that we wanted it to be. So while implanting, we have to a bit of weigh the trade-off between the safety and efficacy, because the more ostial we go, the more myocardial territory we treat. On the other hand, the more ostial we are, there is potentially somewhat higher risk of device migration. On the other hand, if we go too far away, too distally, then we actually manage less side branches and less myocardial territory, so this could be potentially less effective. So actually this sweet spot for the implantation would be around 2 centimeters from the ostium of coronary sinus. But what is most important, we do want to have the neck of the device exactly over and above the natural anchoring points, which is the venous valve. This venous valve, when it's in the neck of our device, it stabilizes it, but it also facilitates endothelialization of the device so that we could expect even earlier symptoms relief in our patient. So I proceed, I rewire coronary sinus with a J-wire, position J-wire in a distal coronary sinus branch, heparin, and we proceed with the deployment. Here, so-called mother and child technique. So with the J-wire distally, I position MPA as distally as safely possible and advance 9 French guide catheter carefully over the MPA. I want to be distal to the implant site. It's good when when I'm already there, I can proceed with advancing the delivery system of the reducer. It is good to stop with the reducer already in the right atrium, just to confirm that I have the device between the first and the second marker band, as you can see here marked in red on this video. So I advance the device to the desired location within the 9 French guiding catheter. I retract the guiding catheter to the most proximal marker band. And once I have just had this device in place, I can start with the inflation. The inflation pressure, initial inflation pressure is usually 2 to 3 atmospheres. But what is important here is that I check the oversizing of the device. I just give a flash with the contrast here to check that there's already oversizing there. And for this lady, this 3 atmospheres was actually fine to achieve this 10% overexpansion. So I have the device implanted. Now my goal is to retract the balloon. To do so, it's quite important to expel all contrast from the indeflator, and it's also important to have in the indeflator a mixture of the contrast plus saline. It should be actually diluted with saline. We should suck it out at least 3 times, and actually this time of sucking the contrast out from the system is quite relevant to perform it smoothly. It's good to be patient at this step to ensure a smooth run of this procedure. And then we advance the, I use the right hand to just gently pull back on the balloon catheter, while with the left hand I advance the guiding catheter until the tip is at the opening of the reducer neck, which you can see on the graph in the corner. I have the guiding just at the neck of the device, but I do not want to have this guiding further than the neck of the device. And so once the whole balloon is already in the guiding catheter, I can take this completely out away. So now I reinsert MPA through the device just for final angiography, confirm position, confirm the desired around 10% oversizing, and the absence of any complications like perforation, dissection or displacement. I prescribed for this lady DAPT for 3 months, comprising aspirin and clopidogrel, and then she continued to aspirin lifelong. So we follow up her as we usually do in our outpatient clinic. We bring all our patients back at 1 month, 3 months, 6 months, and 12 months post-procedure. And we were happy to hear that she is actually angina class 1 at 3 months and at 6 months post-procedure. And this was also visible in the dedicated angina questionnaire, Seattle Angina Questionnaire, which you can see here. The more points you have here, the better you are with regards to the angina. So this is how we do it in our outpatient clinic. We routinely give these questionnaires to our patients at these time points. We also perform exercise testing at 3 months post-procedure. We do a medical therapy check because some of our patients can have their anti-anginals just withdrawn or those reduced. And as an option, but we in our center for research purposes do it routinely as well. We do a follow-up echo, magnetic resonance imaging, and invasive microvascular assessment. And to summarize, I also wanted to briefly comment on the building of angina program and the establishing of effective referral network. In particular, I wanted to emphasize here how critically important it is to keep in the loop of information the general cardiologists that referred the patients to us, to you, to your angina clinic. It is routine for us just to report both the acute result of the procedure, but also the 3-month follow-up with regard to the symptoms relief, not only to the patient when we talk with him or his family, but it's important to each general practitioner, each general cardiologist that referred the patient to us. I say to my team that keeping the loop actually builds your group of patients that you can treat with this therapy. And in my experience, that really encourages this general cardiologist to refer to this therapy. They know, they're aware about the outcome, about the safety, and the potential angina relief, and they refer even more patients themselves or their colleagues, which they speak with each other. So this good news are spreading by the word of mouth. In other words, it's not just between us interventional cardiologists to do a fancy procedure. We do need to keep in the loop of information all these general cardiologists and even GPs to encourage and to reach out to these patients who are not infrequently consulted for several months or years for angina, that the things have changed, and now we have a device that can be actually safely and smoothly implanted using this four simple step approach. Thank you for your attention.